Good afternoon. Today I will be giving my intervention study proposal on childhood obesity. The Surgeon General has commented that if things continue, this could be the first generation to live shorter than their parents. Today, I will be going through my presentation on childhood obesity with an outline shown here. During today's presentation, I will also be providing background commentary that is not on the slide that speaks to the significance and provides added context to the issue. The graph on the right shows body mass index by age group with the respective target levels. Green is good, yellow above means overweight, red is obese. The dark yellow below the green relates to underweight. Obesity contributes to about an estimated 112,000 preventable deaths. National epidemic. This is a national epidemic where 1 in 3 children ages 2 through 19. It occurs when a child is well above the normal weight for his or her age and height. The diagnosis cutoff points determined by CDC are for BMI for the age between 85% to 95%, that equals overweight, and BMI over 95% equals obesity. A child below the 5th percentile are considered underweight. Childhood obesity is extremely costly. Eating healthy and being healthy is not cheap, which is part of the root issue. But it is worth the investment when you look at medical costs and the long-term issues. An obese 4-year-old has a 20% chance of becoming an obese adult, whereas an obese teen has up to an 80% chance of becoming an obese adult. The trends show us that the percent of children obese increases over time and at older ages. Also, unfortunately, there is a link in ethnicity too. Research suggests that extracurricular physical activity levels consistently decrease from elementary to high school, especially in girls. Research also indicates that most adolescents do not participate in moderate physical activity 5 or more times per week, and these patterns persist into adulthood. The higher cost of fresh produce and other nutritious foods is cited as one barrier to healthy eating for poorer families. Americans with limited economic resources simply cannot afford to buy healthy foods, join health clubs, or participate in organized sports or physical activity programs. Studies have shown that as income increases, adults tend to eat healthier foods and exercise more frequently. Society today has a multitude of risk factors that make becoming obese easier than ever. These include high-calorie, good-tasting, inexpensive foods that have become widely available and are heavily advertised. Portion sizes have increased, and we are eating out more frequently. Our children drink more sugar-sweetened beverages than they did in the past, and they are drinking fewer beverages such as water or low or non-fat milk that are healthier for growing minds and bodies. Similarly, the car-dependent design of our community has made it much harder for our children to walk to school and much harder for us to shop and do other errands entirely on foot or by bicycle. On top of these changes, many of our nation's schools have cut back or eliminated recess and physical education programs. Sadly, the advancement in technology has led to less playing outside. Lastly, rural, low-income communities don't have access to nearly as many healthy stores. Listed here shows the prevalence of the various risk factors in the community. Researchers settled on 3 factors after analyzing the results of a survey given to 329 parent-child groupings from child care programs in the University of Illinois' Synergistic Theory and Research on Obesity and Nutrition Group Kids program. Sleeping for at least 8 hours, having an obese parent, and children whose parents restrict their food intakes are the 3 biggest risk drivers for a child becoming obese, with the confidence intervals and p-values listed here. According to the National Sleep Foundation, toddlers need 12 to 14 hours of sleep a day. Preschoolers need 11 to 13 hours, and school-age children need 10 to 11 hours. Additionally, people who don't get enough sleep crave higher caloric foods. The graphs here support the claim that Blacks and Hispanics are at higher risk than their white peers, with the smallest p-values of less than 0.001 for boys and 0.02 for girls, being for Mexicans and Blacks respectively. Also, the diagram shows that the best way to combat childhood obesity is to target as close to the individuals as possible. That means family, interpersonal, or values has a better chance at slowing the onset of obesity than in a person than laws or public policy set forth by the community or government. Numerous intervention studies have been done on childhood obesity. This particular study studied the effects of early life risk factors on reducing childhood obesity, so the effect of sleep or food or breastfeeding, and that effect it had on childhood obesity. For this test, each model accounted for an additional risk factor and removed them to see the effect it had on the BMI Z-score. Model 1 adjusted for child age and sex. Model 2 adjusted for the confounders of maternal age, education level, parity, household income. Model 4 adjusted for pregnancy factors of gestational diabetes and second trimester depression. And Model 6 adjusted for early childhood factors of insufficient sleep, presence of TV set in the room while the child sleeps, intake of sugar-sweetened beverages, and fast food. An interesting result from this study is that they found that there is a lack of testing and funding for early childhood awareness and prevention. Considering the statistics I showed earlier, that obese 4-year-old has a 20% chance of becoming obese as an adult, one would think they would want to target this and stop the disease as soon as possible. A 2010 study found only 10 published studies of poor or fair quality on how to prevent or treat early childhood obesity. National funding is lacking for early childhood. In 2011, CDC granted $18 million to fund childhood obesity research demonstration grants, focused on ages 2 to 12 and covered by the Children's Health Insurance Program. One thing different about this study was that other tests would just measure the social economic factors like income and household education, and found BMI Z-score differences to be between 25% to 40% for Blacks and Hispanics compared to white. This test considered maternal and paternal BMI to be confounders. This test, which was done, other intervention studies, this one in particular, which was done by Johns Hopkins for the U.S. Department of Health and Human Services, identified 34,000 unique citations and included 131 articles describing 124 intervention studies. It was an extremely intensive study, and it included outside peer reviewers who each separately reviewed the study and confirmed the results. As shown here, it singled out 9 specific studies. The evidence was moderate for school-based intervention. It also determined that physical activity intervention is the most effective. Also in my research, I found that there is even a project out there that studies the cost savings between intervention studies and childhood obesity called the Choices Project, which is a collaboration between Harvard School of Public Health, Columbia University, and Deakin and Queensland University in Australia. Shown here are the various steps that have been taken already and classifying them based on prevention type. Primary prevention steps have been taken, like encouraging children to eat healthy and exercise more. The hope is that they will prevent the onset of disease. Secondary prevention steps include getting children on a diet program or various other weight loss steps if they are deemed overweight. And tertiary prevention is to prevent the disease from getting worse since they still have so long to live. Bear with me here, as this is a lot to talk about and digest from this slide. For my research project, I thought to myself, What would be original since so many intervention projects have already been performed, as I found out from the Agency for Healthcare Research and Quality study from 2013. I noticed that today's generation is much more tech savvy and need to have it now. No longer is it go look in a book, rather it's look on Google. I also remember when I was a kid, I absolutely loved research and playtime, and as I got older and video games existed, I became more drawn to that. So I decided, why not blend what I loved to do growing up, one physically active and the other sedentary, and see the effect it has on children. That being said, I have decided to do a study where children will get rewarded with either playtime outside, running around, playing ball, or inside on computers or smartphones or video games. What makes this original is that I decided to do a crossover trial, which I learned about while researching the topic. Crossover means that each group will do each activity, and then after a determined time, switch. Then instead of in a normal study measuring different sets of children to each other, we will measure the same children to themselves and see how they change between one activity or the other. For example, if the same kid gained weight during the technology reward and then the kid lost weight during the physical activity award, then the evidence is stronger because we don't have to account for various other factors like one group having different metabolisms, so the results look wonky. Crossover also is appropriate because based on the lack of severity of the disease, it would be appropriate to give each person both tests. I also decided to do a community-based participatory research because I weighed the pros and cons and I felt that it would be appropriate for the study. The biggest driver for my decision is that prior studies showed that school, home, and community-based interventions were all equally effective. That being said, if I can get the community involved, then they will be more likely to see the benefits, take pride in the study, and want to continue long after the study is over. I have also noticed that many interventions that have already been done, including the two I talked about today, said that getting the public educated and involved is the biggest idea towards preventing childhood obesity. However, there are some drawbacks to this approach, which I consider too, which include, for it to be effective, constant communication and engagement needs to occur. I don't think this will be an issue because of the severity of the issue, and the kids are the future motto. Also, this intervention study might take a knock in the research community because it wasn't done by professionals, rather a community. But at the end of the day, results matter, so I'm willing to take the risk. The intervention will take place at home or at school when the parent or teacher notices a good behavior. I will work with the community to determine a list of good behaviors to reward the children on. Examples could be recess, doing chores, doing homework, eating their vegetables, and so on. We will ask the administrators to limit the reward time to 15 minutes except for recess and track how many per day they get. I was toying with the length of the study and figured that 8 months would be the appropriate length. I am no expert in how long it takes one's body to react to the effects of change in one's normal day routine, but I figured 3 months of each activity, then 2 months to recalibrate, return to normal would be sufficient. I also factored in time of the year and figured if you do the study during the school year, then you can capture both the at-home and the school interaction. Also, you capture the good months of weather for most of the country as opposed to the winter, which is notorious for inside recess due to the cold weather, again for most of the country. So in my case, a study in Virginia would be good weather during my time frames. If someone in the community were a doctor or far more expert in the field of human anatomy, the length of the study could be negotiated. We will measure the subjects using a similar method that I noticed other intervention studies used. We will measure the child's BMI and track the change in BMI compared to the starting BMI of each child. We are interested in a 95% confidence interval, so the p-value of interest will be 0.05. For the sample size, we use the table B.4 from the class notes, 9.5, and wanted an odds ratio of 2, a power of 90%, an alpha of 0.5, and based on our research, about 30% of the population is exposed. That would get us 306 children, but then factoring in a 5% dropout rate, our new desired sample size would be 323 children. We will also solicit all children for the study, not just the obese children or the males or the young children. We feel that the more data we can collect, the better representative result we can conclude. Also, it is important to see how all children react to the various reward methods. Throughout the duration of the test, we will continually check in on children to see how they are doing. I propose a weekly check-in to make sure the children are healthy and there are no issues. At these weekly check-ins, we will track their BMI and the number of daily good behaviors. If need be, we will remove children from the study, which we accounted for this possibility in our sample size calculation. Childhood obesity has been a huge issue, and the risk factors are well known, and as mentioned before, educating the public is the biggest thing we can do. That being said, I really anticipate the confirmation of the numerous variety of intervention studies that have already been done. I am particularly curious as to how large and significant the difference really is. I am also curious if there is a difference between gender, age, group, and ethnicity. The strengths of this approach include a community-based participatory research, which allows the community to get involved and be passionate about the study and possibly get better results. Also, the crossover allows us to use the children as controls, so it removes a lot of the potential errors that could arise. Lastly, due to the simplicity of the design, we could potentially have a limitless sample size and really see the magnitude of the differences. Limitations include certain population groups could be underreported based on the community breakdown. For example, if the community chosen isn't very diverse or heavily Hispanic or heavily African American, then we would be underrepresenting the other ethnicities that are not getting a true representative study. Also, despite the community-based participatory research being a strength, it could also be a weakness if there could be possibility for lack of support from the community, potentially undermining my study efforts. Shown here are my acknowledgements and references. I would like to thank everybody for your time, and I hope everybody learned something about childhood obesity.